So here we are going to focus on bipolar disorder. And bipolar disorder is the type of mood disorder. Let me focus a bit. So mood disorder with recurrent episode of mania and depression. So it is called bipolar. So bipolar disorder is characterized by episode of mania and episode of depression with the particular time of normal mood and activities in between. So if anybody have mood alternative between depression or excessive manic phase, right? We give them the mood stabilizer. It is not the part of this talking about the treatment option right now, but I'm going to a little bit focus because NCLEX board asks this question. So if my patient have mood disorder, we give them something mood stabilizer and we use lithium carbonate. The lithium have a narrow therapeutic index, and usually we started the initial dose 600 milligram. But when a patient under lithium treatment, we have to check the blood level of lithium. The normal blood level should be 1.0 to 1.4. It is desirable. And also we have to monitor the side effect we call lithium toxicity, like blurring of vision, polyuria, lethargy, vomiting, thirst, or discolor of urine, pink or brown. So if we see something like this, we always notify to the healthcare provider. So other medication may also be prescribed for both to reduce the symptom of acute bipolar manic episode or for maintaining therapy. So like anti-anxiety agents may be prescribed to assist the managing the psychomotor agitation and characteristics of mania. Sometimes atypical antipsychotic medication may be prescribed for both of their sedative and mood stabilizing effect. So if I ask you, what are the risk factors of bipolar disorder? The common risk factors are genetics or psychological stressor, sometimes neurological disorder, or substance use disorder, most common underlying factor. I'm going to focus about the sign and symptom of bipolar disorder. So as I told you, the patient who have bipolar, there with a recurrent episode of mania and recurrent episode of depression. So during the mania, all are positive sign. Like during manic stage, the patient are very energetic, impulsiveness, or easily distracted. Also, they're looking for the pleasure or delusion at that time. And manic phase patient lost the memories. Whereas the depressive time phase, all of the signs are negative, like they are very sad, they are empathy, they feeling empty, no pleasure in life, they like to crying, not eating well, they lose the body weight, and also fatigue. A common similarities in manic phase and depressive phase, both cases mood switching or memory loss, and both cases they feel fatigue. Hmm? So let me read it. So the manic phase usually onset around the age of 30. Their mood is elevated or they are irritable when they speak, loudly speak, rapid speak, and also vulgar type. Grandiosity is most common. They have a delusion thinking, distracted, hyperactive, and insomnia, decrease the need for the sleep, or inappropriate, and also fight of ideas. So within short times, they think too much. So mode alternate between depression and excessive mania, the client may be risks to self or others. And in that times, the suicidal thinking is most common, or homicide are the risks. The provide the safe environment is the most priority during the manic stage. And during the manic phase, the client may neglect their daily living activities or nutrition. Provide We should provide the finger food. What are the common question NCLEX board asks, right? So during the manic phase, depressive phase, patient have a depressive mode, dysphonic mode, decrease the interest in pleasure, negative views, easily fatigue, decreased appetite, constipation, insomnia, decrease the libido, or suicidal ideation. So during the depressive phase, the most safety is the priorities, like suicide. We have to protect it. We could provide one-to-one observation, ask the patient directly if they have any plan of suicide. Also, we have to find out sign of suicidal ideation, including elevated mood or giving away the uh, the possessions. Initiate the suicidal precursor. Hmm? Basically, the manic phase, we give them lithium medication, or we give them lamotrigine, individual therapy, family therapy, or group therapies. Whereas the depressive stage or treatment, we give them antidepressant or individual or group therapies or group therapies, right? And next here, we said, what are the other intervention, right? So like here, provide the safe environment is the most priority, as I told you. Remove the hazard objects from environment. Monitor the client closely for fatigue, provide the frequent rest period, and monitor the client's sleep pattern. Use the comfort measure to promote the sleep. Provide a private room if possible, but not in the depressive patient. Manic states. Encouraging the client to express their feelings, use claim slow interaction. Help the client to focus on one topic during the conversation. Ignore or distract the client from grandeur thinking. Do not argue with the client. What are the others intervention? Limited group activities or assess the client tolerance level. So individual counseling, family counseling, group therapy, or ECT is very effective during manic phase. Supervise the client's clothes, choice of clothing, reduce the environmental stimuli, set limit on inappropriate behavior, provide physical activity, and also avoid the competitive games. Provide gross motor activity such as walking. Provide the structural activities or one-to-one activities with the nurses. What else? Provide the simple and direct explanation for routine procedure. Provide administration of medication, monitor for non-compliance. But I said during the manic phase, we must decrease the stimuli. During the depressive stage, one-to-one observation, or during the manic phase, restraint may be necessary if patient poses a risk to self or others. Provide the frequent rest period, monitor the sleep, monitor the fluid and food intake, and provide them high calorie portable snacks we called finger foods. This is the question athletes would ask. And we set limit or give concede explanation, use a claim approach, right? And during the depressive phase, what you can do? I said suicide is most important, safety is the priorities. Ask the patient to verbalize their feelings or ask the patient directly if they have any plan of suicide, or we have to find out sign of suicidal ideation include elevated mood or initiate any suicidal precursor. In the depressive stage, we give them antidepressive or individual group therapies. Is very effective. Here we see a difference between manic and depressive. I already explained it, but I want to little bit recap and then go next. So manic phase, abnormally outgoing, aggressive, and exciting behavior. Easily angry or tendency to talk loudly or shout. Hmm? So mood switching, restlessness, fight of ideas, or patient speak, grandiosities, impulsiveness, poor judgment, decrease the attention span, insomnia is most common. Also, during the manic stage, They like to neglect daily living activities, including eating or drinking. Possible hallucination or delusion is common in manic phase. What else? What about the depression? Just opposite the mania. Patient is quite withdraw. They like to isolate them, right? And also they speak very slow mode, right? And also speak with a low voice and generally untalkative. So in that phase, they have a flat affect, or they like to crying, difficulty of concentrating, possible risks for suicide, lack of grooming or hygiene, change in the sleep or appetite, right? So the goal of treatment to depressive symptomatology. So the I said medication treatment drug of choice is lithium or lamotrigine, right? And also, if the depressive stage, we give them antidepressant or like TCA, tricyclic antidepressant, or SSRI, selective serotonin reuptake inhibitor. Definitely, individual or group therapy is very effective. So this is the basic information about the mood disorder.